All right, welcome to our high-yield explainer on managing venous disorders. We're going to cut right through the noise and get straight to the essentials you need for your clinical review. From the basics of how veins work, all the way to advanced treatment. Let's jump right in.
So, let's kick things off with a scenario you are absolutely going to see. A patient walks in with a swollen, painful leg. Immediately, your brain should be jumping to a core pathological principle that is the foundation for so much of venous disease. We'll get to the answer, but first, we got to understand the system we're even dealing with.
All right, the venous system basics. Before we can even begin to diagnose what's gone wrong, we need a super quick refresher on how the whole thing is supposed to work in the first place.
It really is an incredible low-pressure system that's designed to fight gravity 24/7. Just think about the key players here. You've got the veins themselves, these brilliant little one-way valves that stop blood from flowing backward, and of course the powerhouse calf muscles that act as a venous pump every single time you take a step. These three things, veins, valves, and the muscle pump, they are the bedrock of everything we're about to talk about.
Okay, so let's get back to our patient with that swollen leg. We're thinking it's probably a clot, right? A deep vein thrombosis. But why? Why does a clot even form? The answer is one of the most foundational concepts in all of medicine.
And here it is, Virchow's Triad. Now listen, this is not just some historical term to memorize for an exam. This is your essential clinical framework for understanding why clots happen. If you've got a patient with a DVT, your job is to basically hunt for the elements of this triad. It tells you the story of why this happened to this patient. These three factors, they create the absolute perfect storm for a clot to form. So venous stasis, think about a long flight or a patient on prolonged bed rest. Blood's just not moving. Endothelial injury, that's damage to the vein wall, maybe from trauma or right after a surgery. And a hypercoagulable state, that's when the blood itself is just stickier, maybe due to cancer or genetic issue. You don't always need all three, but the more you have, the higher that risk climbs.
So the bottom line is this: Virchow's Triad isn't just theory. It's literally the recipe for a DVT. Identifying these risk factors in your patient is everything. It's the key to diagnosis and, even more importantly, to prevention.
Okay, so we've used Virchow's Triad to figure out the why. Now we get a Doppler ultrasound and boom, it confirms our suspicion. The patient has a DVT. So what's our immediate move? What's the first-line clinical response?
The standard of care here is direct, and it's effective. Our number one goal, our only goal at this moment, is to stop that clot from getting any bigger, or worse, breaking off and traveling to the lungs, which is a pulmonary embolism. We do this with a two-pronged attack. We use mechanical support with compression stockings to help that blood flow, and we hit it with pharmacology, anticoagulants, to stop the clotting process in its tracks.
Now, treating the DVT is absolutely critical for that acute event. But what happens when the problem is more chronic? What if the clot was just a symptom of a deeper long-term failure in the venous system itself? This affects millions and millions of people.
And that brings us to the root cause of most chronic venous disease: valve incompetence. Remember those little one-way doors we talked about? Well, this is what happens when they stop working properly.
So here's the core issue. When those delicate little valves get damaged or weak, they just don't seal properly anymore. And when that happens, gravity wins. Blood starts flowing backward, we call that reflux, and it begins to pool down in the legs, which kicks off a really serious cascade of problems.
And here are those consequences. That pooling blood causes the pressure inside the veins to just skyrocket. We call that chronic venous hypertension. This insane pressure pushes fluid out into the tissues, causing swelling or edema, and it leads to all the classic signs you see: varicose veins, skin discoloration, and in the really severe cases, painful, non-healing venous ulcers.
So for these patients, we start with conservative therapy, right? Compression stockings, elevating the legs, lifestyle changes. But what happens when that's just not enough? When does the disease get so bad that we have to say, okay, time to escalate our care?
This right here, this is the critical turning point. It's when the underlying valve failure has created so much pressure for so long that the skin and the surrounding tissues just can't take it anymore. They start to break down, and our conservative measures just can't keep up.
So these are your red flags, the signs that tell you it's time to do more. A venous ulcer that just won't heal despite good compression therapy, that's a huge one. But you also have to think about severe symptoms that are destroying someone's quality of life, like debilitating swelling or varicose veins that are getting worse and worse. These signs are telling you it is time for a more definitive treatment.
And that's our cue to start moving towards procedural interventions. This could mean things like ablating the bad veins or other surgical techniques. The goal is the same: eliminate the source of that backward flow, that reflux, and finally lower that damaging venous pressure for good. Okay, let's boil all of this down to 3 super high-yield pearls for your exams. If you remember nothing else, remember these. 1. The most common spot for a venous ulcer is near the medial malleolus, that bony bump on the inside of your ankle. 2. The most dangerous complication of a DVT is a pulmonary embolism. It's a killer. And 3. Your gold standard go-to test for figuring all this out is the Doppler ultrasound. These are absolute must-knows.
And that pretty much wraps up our explainer. We've gone from basic physiology to the acute crisis of a DVT to the chronic grind of valve incompetence and all the way up the treatment ladder. So I'll leave you with this final thought, which is really the ultimate goal in medicine. How do we move from just treating this stuff to actually preventing it? How can we get better at spotting at-risk patients and stepping in before that first domino in Virchow's Triad